Now, these are some of these cases which you rarely find in the modern ICUs actually, and ICUs where in say metropolitan cities, debate what kind, and sometimes we just defined as cellulitis or something, some word actually, surgical site infection or like this. So I'm going to describe some of the serious skin and soft tissue infections which ultimately end up in the intensive care unit. And the best way to do is to always take up a case where you have treated a patient, and this is a patient who is 35-year-old, non-diabetic, normotensive, history of trauma to the neck. She met with a road traffic accident, admitted in a local hospital for 10 days, had some little skin abrasion, unfortunately went into cellulitis and necrotizing fasciitis and septic shock and gas gangrene and multi-organ dysfunction syndrome. So unexpectedly, a good debridement actually was done, and I could see the skin actually being, the normal skin being exposed, so good debridement. And a report which was, and this is a problem actually in India, where sometimes some antibiograph doesn't fit into any kind of, say, susceptibility pattern. This actually stay for years was resistant to cephalosporin, so I presume it is MRSA, but I can't be certain because it was sensitive to amoxicillin clavulanic acid. So sometimes you get funny antibiograms, but that's fine. She received cephalosporin followed by meropenem and linezolid when this kind of blackening took place actually, and was transferred to Max, and so if you see the risk factors for this young girl actually to develop necrotizing fasciitis was none of them actually. She was young, has no diabetes, no obesity, no malnutrition, and none of the immunosuppressive stays. So there was nothing which should actually have led to, so I presume it could be some kind of fulminant infection actually, which could have led to this kind of a serious infection actually. If you see the risk factors of MRSA, you can see prior antibiotic use, of course, cephalosporin and quinoline she received, and the culture, the gram stain which was there was done actually at the time of debridement, which was 2 days prior to shifting, 3 days prior to the patient got shifted to our ICU. She was not on hemodialysis, not non-HIV, not resided. She was a young female actually, so there are no risk factors as such. And you can see here that necrotizing fasciitis is a different condition actually, and that is why not all skin conditions would come to ICU, but there are certain early signs. You can see here that these are the early signs and these are the late signs. And she had all the late signs. She had dermal gangrene. You can see on the photograph that she had all gangrenous material. She had no crepitus, and we did the MRI also, which did not show any kind of, say, gas in the this subcutaneous tissue actually, but had multi-organ dysfunction and shock, of course. She was given standard critical care, which is most important actually in any infection. It's not the antibiotics or some funny drugs, but it is the standard critical care. Good debridement was done, and we were after the anesthesia guy said she is not fit for OT and that she may die during the OT. We needed DOT consent, but fortunately we were able to convince them, and they got the debridement done. And we had sent some cultures, but unfortunately she had progressive shock and multi-organ dysfunction. We changed the antibiotics. She was on meropenem. We changed to imipenem because it has got a better, say, gram-positive coverage than meropenem. We shifted to daptomycin and clindamycin, and this being a sponsored talk doesn't mean that we shifted because I'm presenting because it has a rationale to use. The only rationale was that she had thrombocytopenia, so we thought we want to cover, we had an evidence that this is MRSA, and we wanted to give gas gangrene serum, although the cultures would take some time, but of course she had all features of gangrene, but unfortunately it was not available actually. So if you see the literature, the initial management of necrotizing fasciitis is debride. Surgical management is very, very important. And the guidelines suggest that cover everything with antibiotics the first time and then cut back. So hit hard and then de-escalate. And of course, other support is very important. But the initial appropriate choice, of course, has been more studied in, say, ventilator-associated pneumonia or, say, gram-negative infections, but it is important in gram-positive infections as well. You can see here that sometimes even the best of the clinician, you can see here he making a mistake, the Pope John Paul being introduced as Dalai Lama. So that these kind of mistakes can take place actually. And the important point is that you can see here that if you don't treat the initial infection well actually, and if it progresses to severe septic shock, the mortality goes up significantly. And we know that the Anand Kumar study, and he's a very close friend of mine, always comes to our meetings, that if you delay the antibiotics, the mortality goes up. Unfortunately, even with these kind of seminars and much more understanding about sepsis, still even in those hospitals you can find only 50% of patients in septic shock really receive antibiotics within 6 hours. The guidelines for skin and soft tissue infections are old. They were published in 2005, but we are expecting the guidelines in 2011. And if you see the guidelines, we did nothing wrong, but we followed all the guidelines. You can see here that for most of the infections are mixed infections. You need to cover for, say, gram negatives, gram positives, and if you suspect, say gas gangrene or say gas forming organisms, you need to cover with clindamycin as well. So we did the same thing actually. This is a report of the intraoperative staining which was done. It showed some gram negative bacilli and occasional yeast cells actually. This was the further culture report which came. It showed ESBL E. coli, which was sensitive to cephalosporin sulbactam and was sensitive to imipenem. But we continued daptomycin because we knew that she had an evidence of MRSA infection in the previous hospital. When to add clindamycin? Only one thing actually, clindamycin should be added if you suspect gas forming organism, but the important point is that it has got a cross resistance with erythromycin. So if you have resistance to erythromycin in staph, please do not use clindamycin in these patients. Patients with say PML toxin positive should always receive clindamycin, which is a very important drug in those subgroup of patients. The classification of SSTIs uncomplicated are mainly the skin infections, the superficial infections which are very common. They never come to the ICUs. These are the complicated ones which come to the ICU, and these uncomplicated ones basically can be treated with some kind of say oral ointments or little bit of say dressings and oral antibiotics actually. And if you see the microbiology, mainly most of the skin infections, the serious ones actually have say gram positive anaerobes and gram negative as well. And this was a study which shows that predominantly most of the patients will have some kind of gram positive infections actually, and Staph aureus is a very common infection in these patients. In this study, 30% were methicillin sensitive and around 15% were MRSA patients. If you see the importance of initial antibiotic, and this is the only paper which I could find, that initial antibiotic in gram-positive infections is equally important. You can see here, it clearly states that inappropriate initial antibiotic treatment of MRSA staphylococcus is common and associated with increased risk of hospital mortality. So it's not only the gram-negative, but the gram-positive. If you delay the initial appropriate choice, your choice is not appropriate, the mortality goes up. And you can see here, it is applicable to skin and soft tissue infections as well. So if you consider the patients at risk of dying, you can see here, the initial antimicrobial treatment is very important. Of course, vasopressin administration and other supportive care is equally important. If you see the mortality, whether it is MRSA or say methicillin sensitivity, particularly in elderly patients, you can find a significant difference. You can see that patients with MRSA have a higher likelihood of dying than the methicillin sensitive Staph aureus infections. So always consider MRSA. If you have SSTI, it may sometimes be positive or it may be negative, but still a high index of suspicion is always required. These are the available drugs. We have vancomycin, which has been there for a long time. We have linezolid, daptomycin, and tigecycline and other drugs actually. If you compare all the drugs, you can see here daptomycin, and of course this is not available in India. and these are the non-ICU drugs. It is bactericidal. All the glycopeptides are weakly bactericidal, and linezolid, tigecycline, and other drugs are bacteriostatic drugs actually. And of course, we know that if the patient has severe sepsis or septic shock, we would love to use bactericidal drugs initially at least. But if you compare vancomycin and linezolid for skin and soft tissue infections, you can see here that the penetration or the tissue levels of vancomycin are not acceptable as compared to linezolid. If you compare the outcomes also, if you see compare vancomycin and linezolid, and if you see clinical cure as the outcome, you can see here that the success rates with linezolid are much better than the vancomycin, and the clinical cure rates, of course, are different if it is an MRSA. So if it is an MRSA, the usefulness of vancomycin is debatable actually. And we know that glycopeptide resistance is increasing, and I was with Dr. Chand Vattal from Gangaram Hospital. He said that some of his MRSA, he had 3 strains of MRSA which were resistant to even linezolid. So MRSA resistance to these kind of glycopeptides is also coming up actually. But the important point is that, which is not actually done in our ICUs or our labs actually, is that the MICs of vancomycins are creeping up actually. And we know that if the MICs are high, then the clinical response is not as much as expected actually. The other point is that vancomycin monitoring is not easy actually, because there are different regimens. If you ask a nephrologist, he would say, ki, give 500 milligram and you can repeat after say 5-7 days. So that's all say theoretical, hypothetical. And if you ask the other nephrologist, say, it's a severe infection, give it every 3 days. Because we do not have these say serum levels available actually. So it's all on presumption, and in a serious patient, we can't go with presumptions actually. And it is a recommendation also that if you have life-threatening infections, then serum monitoring of vancomycin is important. So to conclude, if you compare vancomycin and linezolid for skin and soft tissue infection, it looks like linezolid is superior to vancomycin in most cases of MRSA infections. Does that mean that linezolid should be used as a first-line therapy for SISTIs? We know the limitations of linezolid, and you know that most of the ICU patients which are sicker actually, and this patient of course had actually thrombocytopenia, and which is a very common side effect with linezolid actually. And of course metabolic acidosis, QT prolongation, and we want to actually save this drug. In India we do not have say MRSA incidence as much as in the Western world. So is it rational to use linezolid as a first line drug for serious MRSA infections actually? And this is actually, if you see the CDC website, it clearly said that the MRSA incidence and the VRE incidence is increasing actually. And we know that this is a report from the UK, recent report actually, shows that MRSA cases are increasing even in UK hospitals actually. We know that there is a limitation to the drugs, and it's not only the gram-negative actually bucket, but the gram-positive also you will see, although there are some promising molecules coming, but we don't want to actually end up in a stage where we have ended in the gram-negative actually situation, where we have say Acinetobacter only sensitive to colistin. So, and in some hospitals you will find that it is even resistant to colistin. So we don't want to actually end in the state, and it's the right time actually we practice antibiotic stewardship actually. If you talk about tigecycline, it's a very, very good drug actually, although it's bacteriostatic, and we know that, but the problem is that in most of the ICUs, and I know about ICUs in other hospitals as well, and in my ICU, that if you find Acinetobacter, it is only sensitive to tigecycline and colistin actually. So it may not be a good choice to utilize this drug for say MRSA infections actually. So we have to spare tigecycline. Tigecycline is a very good drug. It has got a good skin and soft tissue penetration. But considering the epidemic of gram-negative multi-drug resistant infections, and this is a very vital drug actually. These are the antibiograms. You will always find that most of these bugs actually, you will find E. coli and Klebsiella. And we have 44 cases of Klebsiella which are presumed to be suppose NDML type, which are carbapenem resistant actually. So they are only sensitive to tigecycline and colistin. So we cannot actually afford to use tigecycline for infections of the skin and soft tissue. What about the drug daptomycin? It's a new drug actually, not a new drug, but a new drug in India, of course. It is a lipopeptide natural product. It has activity mainly in gram positive. So it does not cover any gram negative, which is a good antibiotic stewardship. So if you have say MRSA, give only gram positive drugs actually. The good thing it is bactericidal, which is good in severe sepsis and septic shock, and no cross resistance with other antibiotics actually. If you see daptomycin, it is comparable with vancomycin and other glycopeptides, but this kind of an evidence was never available actually. It was never compared in terms of, a superiority was never shown, and this is the only study which came up in 2009 which shows that daptomycin is superior to vancomycin and teicoplanin against MRSA and VRSA stain. So it is not only comparativity, but now we have evidence that when it comes to MRSA infections, daptomycin is superior if you compare it with the other glycopeptides. People are talking, and this is an article which is recent actually, this is the guidelines for MRSA actually. These are 2011 guidelines. And if you see the recommendation for daptomycin, in skin and soft tissue infections which are associated with MRSA, it is graded as A1 actually. The important point again is still we want to practice antibiotic stewardship, and most of the infections, skin soft tissue infections, you need to use it for 7 to 14 days if a good debridement, if good source control has been done actually. This is very important in the ICU population actually. We need to know when we have multi-organ dysfunction. And this is a very good study actually. This was published actually recently, which shows that daptomycin in patients who receive CRT, and this was an analysis of the serum levels, and they said that it is not actually dialysable and it receives a good continuous serum even in CRT. So in terms of the pharmacokinetics also, it is a good drug actually. If you see the recommendations also, the FDA has recommended for bacteremia and community-acquired skin and soft tissue infections. So it is a recommended drug for MRSA actually. So we are talking about stewardship, and it's good that people have started discussing about stewardship in the skin and soft tissue infections as well. And we want to actually spare the drugs which have gram-negative coverage. So we have to make sure that we don't use broad-spectrum drugs, we don't use prolonged treatment, and we have antibiotic stewardship programs even locally at our hospital. Thank you so much.